Before I bring up John, just two quick things about what Stan said. One is, I think it's really, really important that you know when you're paying or when the reimbursement's been being paid by Part A and when it's being paid by Part B. Because there's a lot of things going on in how healthcare is evolving that may change that, and Stan brought up one of those points, so I think we got to be careful of that. And the other thing is, Stan, I learned now exactly how I'm going to approach my wife about both the RV and the boat. Our next speaker is John Higgins. John is the VP and CFO of Good Samaritan Medical Center, one of my favorite hospitals. John is responsible for all financial operations of the medical center, including financial analyst, operational and strategic planning, business development, budgeting, capital planning and acquisition, and forecasting. He's also the site representative for health information management, admitting and registration, and legal services. It sounds like he's the only employee of the hospital today. John has more than 25 years experience in healthcare finance. John joined Exempla in 2003, and prior to that he served as VP of Finance and CFO at St. Peter's Hospital in Helena, Montana. He also served in several finance positions, including System Finance Director and Senior Financial Analyst at Health East Care System in St. Paul, Minnesota. Ladies and gentlemen, welcome John Higgins.
All right, well, thank you for that introduction, and thank you to all of you for letting me share my opinions with you about this important topic. I would like to start by saying that I'm here as an individual citizen today. These are my personal opinions and observations, having watched this as a finance professional for 27 years in healthcare. The clarity is they do not represent an official position of my employer, Good Samaritan Medical Center, which I hope that some of you may come to visit us as visitors. Hopefully we don't have to have you there as patients, but we'll take care of you if you do. So the challenge for hospitals under healthcare reform in the Affordable Care Act. Hospitals are being asked to improve access for those who can't pay, continuously improve our quality of care, reduce the unit cost of the services that we provide, absorb input cost increases, maintain 24/7 availability of public benefit services, all while accepting further reimbursement decreases from government payers already paying below cost. And for those of you who have been in a business world, my question for you is, how would your business have responded to a situation like this? We do have a societal dilemma. We already spend far more than the rest of the world on healthcare, and we're spending more every year. The top line there is the U.S. spending on healthcare as a percent of gross domestic product, increasing and topping out over 17%. Over 17% of every dollar that is spent or earned in this country is spent on healthcare. The rest of the world is hovering right around that 10% mark. And we achieve poorer healthcare outcomes with that spending. You won't be able to read all of this, but I'll just tell you kind of some relevant statistics. In 2011, our life expectancy in the U.S. was 78.7 years. Other countries in the world, Australia, 82, Canada, 81.5, France, 82.2, Germany, 81, Japan, 82.7, Sweden, 81.9, Switzerland, 82.8, and the United Kingdom, 81. So we're not, for all that money that we're spending, we're not really seeing a healthcare outcome commensurate with that spending level. And still, 15% of our population was uninsured. In 2012, the United States and Colorado both had a 15% uninsured rate. So that was 15% of our population, despite spending more than the rest of the world, still didn't have insured access to healthcare. And the deficit spending, of which spending on Medicare made a huge part of it, was really running out of control. The big dip that you see there in 2009, obviously that's when we had the meltdown in the financial markets. But we haven't recovered since then all the way to reduce that deficit spending, and it's projected to continue. And that's really driven by increases in funding, the Medicare program and healthcare costs, and the interest that we pay on all of that deficit. That's really what's driving that continued deficit spending. As a society, we recognize that can't continue. And so a change is in order. And I really like this slide because it really shows there's a balance. Human compassion, the entitlement programs, Medicare, Social Security, versus the economic situation and the debt situation. You can't impact one side of that balance without impacting the other. And that's where the impetus for the Affordable Care Act came from. So one of the things that we were asked to talk about is, given that we've already arrived at this situation with the Affordable Care Act, what is the impact that it's having? So there are direct impacts to hospitals through the Medicare program directly. The one good thing that we can say about it is we have had a reduction in the uninsured. It hasn't eliminated it, but it has reduced it somewhat. Offsetting that, we've had Medicare payment reductions, which is reductions in the market basket adjustments, the inflationary increase, or that sustainable growth rate was discussed before. Even though the sustainable growth rate as planned has not been implemented, the way that our reimbursement rate is calculated from the government, it starts with an inflationary increase, and then they take decreases off of that. And some of those are even just based on what is planned or assumed. So the federal government says, here's your 2.7% inflationary cost increase, but we know that hospitals are increasing their coding level, so we're going to take that off of that 2.7 to mitigate that, and they keep taking those adjustments off, basically cutting in half that rate increase. We don't get to do the same thing with our cost inputs, our inflationary increases. We can't tell our staff that, well, here's your raise, but we know that you're spending more money on Starbucks, so we're taking some of that away from you. The other thing that they've done is put in place what they call value-based purchasing, which sounds like a great idea. But the way that the formula is structured, it basically says that any hospital that is performing at a lower than expected rate gets money taken away from it, or lower than average. So that means half of the hospitals in the country are getting a deduction based on some quality metrics. And some of those metrics are things that you would say are great and should be included. But one of them, the readmission rate, for example, hospitals that have a higher than anticipated or higher than average readmission rate, for any reason. So you come in with congestive heart failure, we bring down your blood fluid levels, get you back to normal. And we educate you about managing your condition before you leave. But if you go home and open your cabinet and pull out your can of full sodium Campbell's soup, we might see you in the hospital in 3 days again. And so we're being penalized on that readmission, even though it's not something that's within our control. The other thing they've done is put in place, it's not the official term, but what I call them is payment experiments, like bundled payment and accountable care organizations. The Medicare payment reductions, we've heard a little bit about this, $160 billion reduction in that market basket update that I described. The hospital readmission program is expected to save $7 billion, or targeted to save $7 billion. Hospital-acquired conditions, $1.5 billion. Disproportionate share hospital payments. So some hospitals have a higher than average proportion of their business that is either uninsured or Medicaid, and the Medicare program would pay a little bit more for those patients to cover the losses on those patients, and that will be reduced as well, impacting the hospitals that most need those additional payments. We talked about the payment experiments, and here's just some headlines about those payment experiments. 9 pioneer accountable care organizations jump ship after first year. San Diego-based Sharp Healthcare pulls out a pioneer ACO program. That was just last month. Bumbled or bundled payments. Bundled payment pilot in California not successful, RAND report finds. Effort to adopt bundled payment across California falls short of goals. But the thing that really concerns me is not even so much the direct impact on the Medicare program and its impact on hospitals, it's the indirect impacts. So one of them is what's the impact of the exchange plans? Many employers are moving to what they would actually kind of call a defined contribution approach to health insurance. There was a change in retirement plan funding several years ago where instead of having a defined benefit plan that when you retire you will receive X amount based on your earnings, it's we will contribute a certain amount of money towards your retirement planning. And that's been in place for many years now in the retirement planning side. Many employers are moving to the same kind of approach. Instead of having to say, we will give you a package of healthcare benefits, they're saying, we're more interested in giving you a contribution to your healthcare, and then you go out and find coverage. And then the other thing that is a potential, not directly through Medicare, but it's the cross-subsidization of Medicare losses. And if you take one thing away from my talk today, I hope it would be this. This chart is showing the shortfall of payments from Medicare relative to the actual cost of providing those services. And it's big and getting bigger. So Medicare, as a government plan, it's not a negotiated payment. Medicare says, this is what we're going to pay. We want to make sure we're paying less or reducing our growth rate in what we pay. And it's just set. And the fact of the matter is the payments that are set by Medicare do not cover the cost of providing healthcare services to Medicare patients in the hospital. And that is not through a mismanagement. It's not through excessive overhead or waste. It is basically the government is the 800-pound gorilla that just says, this is what we're going to pay, take it or leave it. So how do hospitals sustain that kind of a situation? Well, the main line, the main axis, the x-axis going across there is 100% of cost. And the two bottom lines are Medicare and Medicaid, which represent about half of the business of a typical hospital, not paying the full cost of the admission. To date, we have been able to offset those losses on Medicare with private payer insurance, which is the upper line. That is where a lot of pressure is coming as well. That's what's driving a lot of those employers into thinking about defined contribution plans for healthcare. And the thing that really concerns us is through the exchanges, through employers dropping their private health insurance and putting their employees on exchange type programs, that we'll see a real reduction in that reimbursement rate, not only from Medicare, but from the private health insurance plans that are currently sustaining those Medicare losses. We're also seeing that there's a lot of impetus to narrow networks. So especially here in Colorado, most health insurance plans have really focused to date on inclusivity in the network. We want to make sure your doctor and your hospital is in our plan so that we can sell a product that you will be interested in. A study said that networks are really narrowing. So broad networks is the upper category. It's dropping 41%. A broad network is one that has at least 70% of the hospitals in the service area included in the plan. Narrow networks only have between 30 and 70% of the largest hospitals, and ultra-narrow networks have only 30% of the largest hospitals. Narrow networks are expected to grow by 150% and ultra-narrow networks by 173%. So what that really means is those plans are saying, we're not going to offer choice to our enrollees anymore. We're going to narrow down which hospitals we're going to include in our plan, and you will only be able to go to those hospitals. So we're seeing those network arrangements. And the problem for a hospital is what happens if you're not included in the network? All of a sudden those patients who would have come to you from your service area are going somewhere else. And the impact for patients is, what if that hospital that you want to go to is either not your local hospital, not a hospital that you know good things about from past experience, or maybe not even be in your local area. We're seeing a lot larger member liabilities on the exchange. This is some data from Colorado. The bronze plan, so we know that there are tiers of coverage, bronze being one of the lowest and gold being highest. The bronze plans with a $5,000 annual deductible per person are the biggest growing plan being offered through the exchanges right now. The problem that has for hospitals, if you come in, you have a service, the cost is $10,000, Historically, about the average for the deductible would have been $1,500 to $1,700. That's what you would pay out of pocket, and the insurance would pay the rest. That's what we would collect from you as the member. Now, for that $10,000 admit, if your annual deductible is $5,000, that first $5,000 comes out of your pocket, which is an impact to you. It also increases our losses in terms of not everybody has $5,000 that they can pay for that right out of pocket because it comes all at once when it's a hospital admission. So that increases our uninsured costs. There's also a lot of uncertainty about the sustainability of the exchanges. So what this chart is saying is actuaries agree that the right risk balance requires 40% of the enrollees to be between 18 and 34 years of age. And on this chart, that would be dark green. And what you don't see on this chart is a lot of dark green. So what that really means is even where we do have exchanges, they're not getting enough of the younger, healthier people as a percentage signed up to cover the higher utilization that'll be from an older population. And will those really be sustainable? And the problem with unsustainable is, well, what happens when their expenses exceed their revenues? They're trying to reduce rates that are paid to the hospital providers. So that concerns me. And then continued regulatory uncertainty. The administration continues to call audibles on the implementation. We're subject to election outcomes at state and federal level that might influence where the future of the Affordable Care Act goes. The regulatory and rulemaking process. So as an act, it basically says, here's what we're going to do. And then it's turned over to agencies to implement, and they have their own rulemaking process. Future congressional action, influence of the courts. In the 113th Congress, 250 bills were introduced to repeal or modify the Accountable Care Act. Repeal of the individual mandate, 25 bills. Employer mandate, 16 bills. Repeal of the payment advisory board, 4 bills. So many bills that are either underway or being voted on, and the outcome of those bills will impact the implementation of all of these plans. We also have the problem of increased access and demand, where we do have people now who were previously uninsured, who now have insurance. They're going to be trying to access services, and not only is that a difficulty from the primary care physician side, because those patients may not have been able to have access to the primary care physician before. They're also inexperienced in how to access the healthcare system. Many of those uninsured patients would wait until they were very sick and then come to the emergency department. Well, if we're really going to achieve savings, we need to change those behaviors, but they're not really well versed in how to use the system. And we also have disruptive innovation and cherry picking. It was previously referred to as innovation. And innovation is a great thing. Competition is a great thing. I truly believe that. I'm a capitalist at heart. And the difficulty that it has in this particular situation is the way that innovation looks is we have individual offerings, let's say, that say, well, we're going to not care for the entire hospital service. We're just going to take outpatient imaging. And we'll build a freestanding outpatient imaging center, and we can sell it to you for less than the hospital will sell it to you. By the time we've pulled out all of those services and are left with the services that nobody else wants to provide, that the community expects the hospital to have available 24/7, emergency departments, intensive care units. Not only do we have the cross-subsidization problem with Medicare and private insurance, those other services that are being cherry-picked out of hospitals are what fund the availability of those community benefit type services. And who's going to be left that wants to pay the full cost for those services? We already have a lot of complaints of how can it possibly be $800 for an emergency room visit? Well, that emergency room is staffed 24/7 with trauma experienced physicians, and it's in a facility that provides around-the-clock laboratory imaging and surgical services. You're not going to see that in that freestanding imaging service. So potential hospital responses. So we will obviously always be looking towards improvement in operating efficiencies. But the problem is the scope of the dollars that are being in play here are huge. One thing we can always look at is workforce reductions. And there was a study by the Center for Studying Health System Change that said for every $100,000 reduction in inpatient revenues, a hospital reduces its total staff by 1.69 full-time FTEs. That means a $10 million reduction in reimbursement, whether directly from Medicare or indirectly from the changes happening on the private insurance side, means a hospital would have to reduce 169 FTEs. And my question for you, it's not a value judgment. It's just something I would want you to be aware of. If this is the situation hospitals are being faced with, how many other patients is your nurse going to be required to care for when you're admitted as an inpatient? Right now in our hospital, general med surg nurse-to-patient ratio is 1:5. Your nurse is taking care of 4 other patients besides you. We think that's an appropriate level of staffing to make sure we're providing safe and effective care. But if we have to make these kind of workforce reductions, I don't know what really will happen to that nurse-to-patient ratio. Hospitals can look at reducing choice. For one of the most popular to discuss items is hip implants. Right now we offer whichever hip implant the surgeon uses, that's what we offer. But there's a big discrepancy in price between a Smith & Nephew hip and a DePuy hip. And right now we offer that choice, but that our actual acquisition cost for that hip implant uses up almost all of the Medicare reimbursement. And so if that reimbursement is reduced, or if our ability to cost shift to private insurance is reduced, we may have no choice but to limit which kinds of hips we'll say are available to the physician. We'll look at shortening length of stay. I came from the Minnesota healthcare environment where in the late 80s and early 90s, there was this huge impact of managed care. And it really focused on reducing length of stay to the point where a newborn delivery was trying to push to be a one-day stay. I'm not sure that's the right answer in all instances. And again, the question for you is, how long will you be able to rehab in the hospital after you have your knee replacement? And then those operational changes can only get us so far. Sooner or later, we have to start looking at strategic kinds of responses. Consolidations and mergers, that's happened in other markets in the country. What happens in consolidation and merger is typically that not everybody survives. And what happens if the hospital that gets consolidated out of existence is your local preferred hospital? We may have to look at eliminations of services. An emergency department in the hospital is a very expensive thing to maintain. And it's part of the community expectation that we have those services there round the clock. But at some point, do hospitals start to have to look at services that may not be covering all of their own costs because there's no opportunity to cost shift to anybody else anymore, and what gets eliminated? And then the other thing that's always been discussed is limiting Medicare. So far, hospitals per se are not in a big way opting out of the Medicare program, but they are opting out of some portions. The Accountable Care Organization, many providers have pulled back out of that. Bundled payments, our hospital, my hospital, was signed up and then decided that the way the program was structured, it made no sense to continue. We pulled out of the bundled payment experiment. Some physicians are opting out, and that's the situation right now. But what really is going to happen when we no longer have that opportunity to cross-subsidize between the payment plans and hospitals are really trying to make sure that they can remain in existence? Will they or will they not choose to accept Medicare in the future? That's unknown. So we'll take questions afterward. Thank you.
So please make sure you're filling out your Q&A cards. We will get to that right after Mike's talk. John, I feel like I was so excited about your talk, I'm going to go out and sell all my stock in hospitals. I mean, look, the government's saying to them, you lose 9% on every patient you do a lot more of those and you'll be better off. I don't know how you manage that. Next up, we've got Mike Gurali. Mike is an expert in the funding of healthcare costs and the risk for businesses and individuals. He's the author of a book called What You Don't Know About Retirement Will Hurt You, and the upcoming book, Health Happens, How Medicare, Medicaid, and Obamacare Will Affect Your Financial Future. He's been a featured speaker at numerous national conferences on the topics of retiree pension, healthcare obligations, along with the recently enacted Affordable Care Act. His companies, HRSB and Jester Financial Technologies, are at the forefront of developing software tools to forecast healthcare costs in retirement. Please welcome Mike.
All right, I'll try to get through this quickly for you so that we can get to questions and answers. Okay, so real quick, I'm going to not use that microphone. Can everyone hear me? Can you hear me in the back? No? Okay. All right. So I have to use the microphone. Okay, so can I get everyone to stand up for a second? You've been sitting for a while. Can I get you all to stand up? Except the young lady in the front. She doesn't need to stand up. She's going to sit down in a minute anyway. But, all right, so of all of you in the room, how many of you are on Medicare? Stand up if you're on Medicare. Sit down if you're not. Okay, so good portion. Now, of those people who are standing, how many of you are on Medicare Advantage? You stay standing, everyone else sit down. Okay, so in this room, it looks like we're probably pretty representative of the country. You can all sit down. When you look at Medicare Advantage, it's about 30% of the population is on a Medicare Advantage plan. It's actually been growing. There was talk when the Affordable Care Act was passed, the Medicare Advantage, or Part C as it's called, would go away. But I'm not going to go into a lot of detail about Medicare Advantage. What I really want to talk about is financing. Because you've heard from a couple of the speakers, Dr. Jack and from John and Steve, really how all of this is impacting things. And before I forget, I want to kind of talk just about Kaiser. Anybody on Kaiser Medicare Advantage? Okay, so when we're talking about all the issues that come up with the Affordable Care Act and the exchanges for people under 65, Kaiser's probably a good example. Are all of you aware that with the exchanges, if you didn't qualify for a subsidy or if you didn't make enough money, you go on Medicaid? That's part of the expansion of the Healthcare Act. So if you go on Medicaid, you can actually elect Kaiser. Okay, so a lot of the people who signed up, who were eligible for Medicaid in Colorado, chose Kaiser as their healthcare model. Now, how many of you think that's going to have an impact on your Medicare Advantage plan with Kaiser? Is that right? You've got more people in the system, there's more costs, Medicaid we've seen doesn't pay as much, so there's definitely going to be impacts here. We see it happening all the time. John brought up the hospitals and the doctor networks. In the exchanges, those networks have really been reduced and narrowed. We would expect that to continue to happen in Medicare Advantage as well. Anyway, let me talk a little bit about healthcare financing, because I think that's really the piece that we want to focus on. First of all, for Americans 60 and older, healthcare is one of the biggest expenses. And for most people, they really don't know anything about it. So, I'm going to kind of go through that. Matter of fact, there was a survey done by Sun Life. 92% of Americans did not have a plan for healthcare when they retired. How many of you had a plan when you were in your 50s thinking about, all right, how am I going to fund this? Am I going to do it the best way? Anybody out here? Okay, and if you did, was it hard to find data? Was it hard to figure that out, what those costs were going to be? I was very excited this week. I got to go out with my daughter and tour a couple of colleges for school, and she plays volleyball. So there were some schools that had offered her a full ride scholarship to go play volleyball, and she accepted one on Friday. So I'm so excited. I'm like, God, I don't have to pay for college, right? This is great. And then I started working on my presentation, and I'm like, wait a second. All I did was just save money from that pocket to be able to pay for healthcare costs when I retire. Because right now, Fidelity, which all of you have heard of Fidelity, they talk about the fact that healthcare costs for a 65-year-old couple is $220,000. That's what you're going to spend. So that's actually the cost of an Ivy League education right now, $220,000, somewhere in there. That's the cost today. If you're 50 or 55, we better be hoping Steve's right on the technology side, because the numbers that we look at, those numbers are going to get really big. I won't, when you look at Medicare to collect Social Security, one of the things that's come up is that you actually have to sign up for Medicare to get your Social Security, assuming you're retired. So anybody realize that when they just retired recently, that you had to do that? That's one of the things that you have to do. Also, Medicare is actually part of the individual responsibility, even though it's not really affected in the Affordable Care Act. You still have to have Medicare coverage, Part A, to be considered covered and not have to pay a penalty under the Affordable Care Act. We kind of talked about the different premiums, but if we look at costs, anybody here, a lot of you are taking Part B, right? Has anyone noticed that the more money you make, the more you pay for Part B? You might be talking to somebody and saying, well, geez, my Part B premium is $104.90, but mine is higher. Why is that? Medicare is means tested. Do you all know that? Does everyone know in the room? As I can tell you, about 6 months ago, we did a presentation in front of a group of CPAs. Only 4 CPAs out of 60 raised their hands that they knew Medicare was means tested. Okay, so how much money you make in retirement is going to impact what you pay for Medicare. Now, what does that have to do with your Medicare Advantage plan? Well, it's a cost, right? It's just another cost that the government is charging you if you've been successful and you've saved money to help offset those costs for Medicare. So while it may not be built into your Medicare Advantage plan right now, it is a cost that's there. Other factor, Medicare has inflated at over 7% for the last 47 years. So when Harry and Bess Truman, did you all know that Harry and Bess Truman were the first Medicare beneficiaries? 1 and 2. They had the first 2 cards. When they started, $3. That's what Part B was. It went up to $104.90, right? It stayed the same last year. That was great. Why did it stay the same? Well, because there was this little doc fix that was put into legislation that said we're going to cut doctors' costs by 24%, so therefore we don't have to cut Medicare premiums, Part B premiums. Didn't happen, but you still didn't have to pay Part B, which is good, right? Nobody's complaining in this room about that. That's good. But the fact is, Medicare has inflated at over 7%. Now, I'm not a fortune teller. I don't come from a family of fortune tellers. All I can do is look at the past. But if something's inflating at 7% and has over the last 47 years, and we have this huge baby boomer generation that's going to come into the system, I have to think that costs are going to continue to escalate. Unless Steve is right, and nanotechnology solves all of our problems. But, so from a planning perspective, I think what you have to understand is you've got to be aware of costs and understand that in the future, these are going to go up. So again, means testing, it started was actually passed in 2003, started in 2007. Here are the premiums. So if you make under $85,000, it's $104.90. If you're over $214, it's $335.70. Doesn't seem like a lot right now. But again, think of that 7%, 6% compounding. In 20 years, that could be a big number. Also, Part D is means tested. So while you may have your Part D card or Kaiser may combine it, you still have an extra premium that you potentially have to pay. Now, something that's not on here is that the administration has put into the last couple of budgets a proposal that would change this means testing. It would actually take it from 4 to 9 brackets and would lower the number down to 80,000. So you can see that there's an eye on how do we take people who have saved, been successful, done the right things for retirement, and charge them more for their Medicare costs. That's one of the ways the government is going to look to finance this. And it's, again, you can look in the records. We actually have in our book we talk about that. So what's income? Well, income is basically everything. It's your Social Security, it's your pensions, it's your capital gains, your dividends, IRAs, all of those are considered income. What's not? Health savings accounts, Roth, we talked just briefly about that. So what you want to be doing when you're thinking of financing, if you've still got time, you want to be thinking about, all right, what can we do? How can you fund some of these accounts that won't incur a tax, won't put you into that higher bracket? And that's one of the things I want to leave you is, with, if I can, is that you have to think of healthcare financing as separate from your retirement plan. And I can tell you, I talk to financial advisors all the time. They do not understand healthcare. They aren't planning for it. And I can tell you that as a matter of fact. So you've got to take it upon yourself, or your family's got to take it upon themselves to really learn this, because most financial advisors, all they're going to tell you, save more money, put more money away. And while that's good, I'm not saying that's bad, you can do better. I won't go through the pros and cons, just in essence of time here. So what's the future of Medicare Advantage, though? I mean, there's all these different things. I put a couple of links up here. There's a website. Anybody been to Obamacare Facts? I know Mark has. We've been there. You know, if you Google Obamacare, you'll get that website. It's probably one of the most hit. You know, if you read that, everything's good. If you read the Medicare Trustees Report to some extent, don't worry about it. It's fine. Paul Krugman, who writes the New York Times, would tell you it's all fine. Maybe it is. I hope it is. I hope everything's good. But the reality is that when they start cutting Medicare Advantage, when any insurance company has cost pressure, right? So Humana, as an example, 70% of their revenues come from Medicare plans. So when they get cut, when the government does finally make those cuts that they've been talking about, that they keep delaying, what's going to happen? Well, Humana's either going to raise your premium or they're going to pass on, reduced benefits. That's what insurance companies do. They're in the business to make a profit. They're not going to take a loss. Hospitals, unfortunately, can't do that, neither can doctors. They have to continue to treat. So with that, I think just in concluding, understand Medicare Advantage, of course, is a very popular program. I don't see it going away, but it is going to have some changes, I think, as we go forward. The baby boomers are going to have a big impact on Medicare and its funding, and so you need to be preparing and figuring out. And the other thing I'll tell you, too, talk to your children. I mean, have these discussions. You may all be doing that, but if you're not, talk to your children. Let them know. Let them know, everything about what's going on. I know as a society we don't do that, but you really need to, because they're going to be the one, if something happens in a lot of cases, that are going to have to step in and try to figure out what to do. So talk to them about these things. Educate them. And then again, we're going to see decreases, and healthcare costs are significant. $220,000 is not a small number. So with that, thank you. Appreciate it.
So we're going to take a relatively short break, probably about 5 minutes, but I just wanted you to know that I was paying attention to the three speakers, and I've come to one really important rolled-up conclusion. Don't get sick. Don't get sick. So let's take 5 minutes. We're going to set up the stage for questions. Make sure you get your questions in, and then please be seated up. Thank you.